Good morning, everyone. I'll be presenting a case report on unilateral advanced chemo-resistant retinoblastoma. Thank you. So, I'm presenting a case of 3-year-old male child who presented to ophthalmology OPD with complaints of whitish pupillary reflex in left eye for last 6 months. According to his parents, the child was apparently asymptomatic 6 months back when they noticed a whitish reflex in pupillary area of left eye. It was not associated with any pain, redness, watering, or deviation of the eye. His prenatal, natal, and postnatal period was uneventful. Immunization status is complete as per his age, no developmental delay, and past history and family history was not significant. On examination, visual acuity in right eye, child was reading Leah symbol at 6 meters, and from left eye, he was denying any perception of light. On ocular examination, right eye was within normal limits. In left eye, Hirschberg reflex was 20 to 30 degree exotropia, and child was not taking central fixation from left eye. Pupil was mid-dilated, sluggishly reacting to light, and leukocoria was present. Rest anterior segment examination was within normal limits. This is a clinical photograph of the same child where we can see leukocoria present in the left eye. On fundus examination, in right eye, disc and macula was healthy, as we can see in this fundus photograph. In left eye, a large yellow color solid mass was seen right behind the clear lens, and no further details of fundus could be visualized. His radiological investigations were done. Firstly, ultrasound was performed at the time of presentation, where a heterogeneous, echoic, irregular lesion was seen 7.7 into 8.2 mm in size in the posterior chamber of the eye, abutting the lens anteriorly with macrocalcification. As we can see in this photo, there is macrocalcification. Then MRI was done, where a well-defined lobulated lesion was present in the posterior chamber of left globe with patchy areas of calcification. The lesion was iso-intense and on T1 weighted image and hypo-intense on T2 weighted image. These two are the axial and coronal section of the MRI T2 weighted images. On the basis of these clinical examination and radiological investigations, a working diagnosis of left eye retinoblastoma was made, IRCB classification group E. For treatment, we planned 6 cycles of intravenous chemotherapy, which were given at 4 weeks interval, carboplatin, etoposide, and vincristine in the doses mentioned. Then a repeat MRI scan was done at the completion of these 6 cycles, which showed a residual lesion with calcification, retinal detachment, and subacute vitreous hemorrhage. A repeat B scan was performed, where there was a residual partially calcified lesion 7.2 into 7.9 mm in posterior chamber of left eye with subacute vitreous hemorrhage. As we can see, the size has not actually shrinked on these B scan images. Since I did not show any response to the intravenous chemotherapy, thus enucleation was planned. Enucleation was done by myoconjunctival technique under general anesthesia, and the specimen was sent for histopathological examination. The histopathological examination confirmed the diagnosis of retinoblastoma and showed high-risk characteristics. This is a clinical photograph. The first picture shows the enucleated sample of the whole eyeball. Then in other 2 pictures, we can see the cut sections of the eyeball and the tumor done under the pathology guidance, where we can see a large white color tumor mass in the posterior segment of the globe. This is the histopathology report of the same patient, where we can see high-risk characteristics like choroidal involvement, ciliary body involvement, vitreous involvement, and subretinal space involvement. Further 6 cycles of intravenous chemotherapy was given at 4 weeks interval, and patient is now doing well with a well-fitted ocular prosthesis, and he's kept on 6 monthly follow-up. This is the clinical photograph of pre-operative and post-operative. My take-home message from my side is every child presenting to ophthalmology clinic should undergo a dilated fundus examination, no matter what the presenting complaint may be. And before operating any child for congenital cataract or any other grossly visible disorder, a B scan must be performed to rule out concomitant tumor in the posterior segment. During treatment of retinoblastoma, our aim is to save life first, then the globe, and then finally vision. Thank you.
In your case, The investigations which you did was a B scan and an MRI.
Yes, sir.
Why did you choose MRI and not CT?
Because sir, the soft tissue, for soft tissue we do MRI. So we wanted to know the extent of the extraocular muscle involvement and the soft tissue involvement.
Your clinical diagnosis was retinoblastoma?
Yes, sir.
So which is a preferred modality of radiological investigation in a retinoblastoma case?
Sir, CT scan can be done because calcification and other things are there, but we wanted to see the involvement of optic nerve, extraocular muscles, because we were actually planning.
So that can be seen in CT as well, when you need to rule out pinealoblastomas and calcifications. So preferred choice is CT scan, if
Yes,
I'm not wrong. And secondly, the size of the tumor which you mentioned was pretty small.
Sir, it was involving more than 50% of the globe.
You said less than 10 millimeters.
Yes, sir.
How can that involve 50% of the globe then? Less than 10 millimeter is 1 centimeter.
Sir, in ultrasound, the dimensions were 7.7 and 8.2, but when we confirmed with MRI, its size was around 10.6 in the longest diameter. Ma'am, it was 21 point. Yes, ma'am.
And in the grossing also, the tumor, the white part was in the centrally placed rather than on the posterior aspect.
Yes, sir. But it was abutting the lens also. It was seen right behind the clear lens, and it did not show any improvement on intravenous chemotherapy. We thought of giving another 4 cycles of intravenous chemotherapy, but size did not shrink at all. So we went ahead with enucleation. And at that time, at my center, there was no option of intra-arterial chemotherapy, and so we landed up with enucleation only.
Yeah, there are a couple of differentials which very much mimic retinoblastomas.
Yes, sir.
And the way the presentation is that it's so anteriorly lying, it's not responding to any of the 6 cycles. Hardly there was a response.
Yes, sir.
And the age is 3 years.
Yes, sir.
So,
Yes, sir.
I actually had a case when I was doing my fellowship, which was mimicking retinoblastoma. We did enucleation. Later, it was found to be something else. So you have to be, and the histopathology was really tricky in that case. Probably, no, vitreous biopsy is not advocated because the patient did not have vision. The patient was not getting salvaged with the chemo. So, and the high suspicion of retinoblastoma was there. And her slides, she later said there was a high risk factors were there.
Yes, sir.
Did you do the adjuvant chemotherapy later?
Yes, sir. We gave 4 more cycles of chemotherapy.
4 more cycles.
Yes, sir.
So,
no, ma'am, there was no involvement. Ma'am, in our case, we could excise only 7 mm, but ideally it should be at least 10 mm. But we could salvage only, we could take out only 7 mm. Thank you, sir. Thank you, ma'am. Thank you, everyone.
let's have the next presenter, Nikki Mehta.
Good morning, everyone. Myself, Nikki. I am second year PG resident from Safdarjung Hospital. I'll be presenting case of proptosis with triradiate spread. A 48-year-old male presented with complaints of outward protrusion of right eye since 4 months, which was insidious in onset, gradually progressive, associated with mild pain and redness, and associated swelling of right side of forehead. There was no history of any diminution of vision or double vision, no increase in protrusion on straining or cuffing. There was no significant past history or family history, but he had a history of tobacco chewing for the last 30 years. On general physical examination and systemic examination, no specific findings were noted. Coming to ocular examination, his best corrected visual acuity in right eye was 6/6 parts, and in left eye it was 6/6, with normal color vision and contrast, and slightly elevated intraocular pressure in right eye. Kastenbaum's limbal motility method showed limitation of movements in right eye in all gazes, with dystopia of 11 mm in vertically downward direction and 5 mm in horizontally outward direction. Hertel's exophthalmometry showed significant proptosis in right eye. On inspection, Napziger sign and Wern's view showed asymmetry with right cornea appearing first. There was abaxial proptosis in down and out direction, we could see right subbrow fullness and diffuse swelling over right subbrow area, which was extending to forehead and temporal fossa. There were few dilated veins. Lack of ophthalmos of around 3 mm was noted. There was no erythema, discoloration, sinus fistula, no visible pulsation or an increase in proptosis on bending forward or Valsalva maneuver. An ill-defined firm mass in right subbrow area was present, which was extending to temporal fossa and forehead. It was immobile, fixed to underlying structure. Fingers could not be insinuated. It was non-tender with normal temperature, non-reducible, non-compressible, with no palpable thrill or pulsation. Coming to anterior segment in right eye, there was diffuse congestion, mild chemosis, and few prominent episcleral vessels were present. Rest of the anterior segment in right eye and left eye was within normal limit. In posterior segment, few choroidal folds were seen in right eye. Rest of the findings were within normal limit. This is depicted in this diagram. To summarize, a 48-year-old man came with the complaints of outer protrusion of right eye for 4 months with swelling in right subbrow area, right forehead extending to the temporal fossa, which was gradually progressive, associated with mild dull aching pain. On examination, his vision was spared with normal color vision and contrast. There was abaxial proptosis and dystopia with limited extraocular movements. There was diffuse congestion, chemosis, and prominent episcleral vessels and few choroidal folds. On the basis of our clinical history and examination, our differentials were lacrimal gland carcinoma, sphenoid big meningioma, osteosarcoma, and metastasis. Routine investigations were done, which came out to within normal limits. On imaging, contrast-enhanced CT scan was done, which showed triradiate spread, that is, intracranial spread, as we can see in this picture, intraorbital spread, and temporal fossa mass. Bone window showed frontal bone destruction. Our next step was incisional mass biopsy, which was done, and few pieces around 3 to 4 mm was cut out and sent for histopathological examination. This is the picture of patient post-op day 1 with sutures intact and dystopia. On his histopathological report, tumor cells were arranged in gland ducts and cords with atypical mitosis. Cells were positive for pan-CK, CK7, P63 with high Ki67 proliferation index. The features were suggestive of primary ductal adenocarcinoma. As this was a case of metastasis with intracranial spread, multidisciplinary approach was taken, medical onco and neurosurgery opinion was done, PET scan was advised, and palliative therapy was considered. Few words on our case. It is an aggressive tumor which constitutes 3% of malignant tumors of lacrimal gland. Mean age at presentation is 60 years with slightly main predilection. Most common presentation is palpable mass, proptosis, and pain. It has poor prognosis and high mortality. Take home message from this case is proptosis with triradiate spread may be presentation of many diseases like sphenoid big meningioma, lacrimal gland carcinoma, metastasis. Multidisciplinary approach is the need of the hour. A simple biopsy can be life-saving, as definitive diagnosis can be made on histopathology. Thank you.
After getting the histopathology, what did you do? I missed on the slides. After getting the histopathological diagnosis of adenocarcinoma, what did you further do?
So firstly, we advised the patient to get a neurosurgery and a medical onco referral, as it has intracranial spread and medical onco.
It was a localized intracranial spread, no?
But the frontal bone was totally destroyed,
yeah.
And on doing biopsy, when we were taking bits and pieces from the mass, it was very friable and there was like extensive bleeding from the mass.
Mm.
So we didn't do the debulking during this incisional biopsy, and we didn't plan for like exentration and anything because it has an intracranial spread.
What did your neurosurgeon say?
Neurosurgeon people say it can be like excised, but the prognosis was very poor, and patient came from the poor background. He didn't want.
And what about the radiotherapy department?
Radiotherapy was advised, but patient didn't follow up. Because of the poor prognosis, he didn't follow up and lack of the family support.
So during follow-up, you don't know what happened. It didn't come back to you.
He was under follow-up for 2 to 3 months. When radiotherapy was advised, his family support, they took back because of the financial crisis, and he literally went without follow-up.
Actually, your case could have been very good if the further follow-up and treatment.
Yeah, because of the patient constants, we couldn't follow up this patient.
You have diagnosed and left the patient, and straight away a treatable lesion has been made to go to the category of palliative.
Because of the patient contracts.
It was not to the extent that patient needs palliative care as of now. Could have been managed well.
It's from Safdarjung Hospital,
Yes,
na?
sir.
There are some Pradhan Mantri course Yojana and all, which does help these poor patients. So if you could follow up, probably they can be helped out.
He was
In
not-
AIMS, it's Pradhan Mantri course Yojana for very, very poor patients is working for years and years. So
Yes, ma'am.
that way
We
they
have counseled him about this, but the literacy and the lack of the family support was hindrance. मैंने सर बोला भी था एम्स चलाओ, but
वहाँ पर तो सब फ्री हो जाते हैं. चलो, anyways.
thank you, sir.
We'll have Ruju next. She needs to go to some other session. ठीक है शालिनी? नीचे सबसे last line.
Good morning, everyone. My topic for today is many phases of congenital hypertrophy of retinal pigment epithelium. It's not working. My topic for today is many phases of congenital hypertrophy of retinal pigment epithelium, CHRPE. CHRPE is a benign hematomatous condition characterized by hypertrophy and hyperplasia of retinal pigment epithelium. Previously published articles either focused on clinical features of CHRPE or its systemic associations such as familial adenomatous polyposis, such as Gardner's syndrome, or its progression to adenocarcinoma. So this actually made us realize a need for more comprehensive study which will aim at analyzing the clinical presentation, systemic association as well as its progression. So we conducted a retrospective consecutive case series which included 70 cases or 78 eyes with CHRPE over a period of 30 years. In our series, patients were ranging from age 11 to 64 years with median age being 34 years. Almost all the cases were asymptomatic. 89% cases were unilateral, whereas only 11%, that is 8 cases, had bilateral presentation. CHRPE usually has a pigmented area with an area of a lucent zone. Almost all cases, that is 90%, had flat lesion, and most frequent location was superiotemporal quadrant, seen in 51% of the cases, with median largest basal diameter being 5 mm. Depending on its number and morphology, it can be further divided into solitary, seen in 70% of the cases, grouped, seen in 14% of cases, and atypical, seen in 16% of cases, that is 11 cases. And all these 11 cases with atypical CHRPE were then sent for colorectal colonoscopy, and out of them nearly 50%, that is 5 cases, were detected with familial adenomatous polyposis, which in turn almost always carries a risk of impending colorectal malignancies. All these cases with CHRPE were then followed up for a long time, and out of them 6 cases were diagnosed with RPE adenoma, and out of these 6 cases, 4 cases eventually progressed with RP adenocarcinoma, which were then treated either with plaque brachytherapy or enucleation depending on its size. Also, RP adenoma was confirmed on OCT with an area of hyperreflectivity and backshadowing. So, previously done studies were mostly retrospective, meaning it were done in cases with familial adenomatous polyposis and presence of CHOPY was detected, whereas our study had the largest sample size to our knowledge and it was a forward study. So, CHOPY, all the cases were with CHOPY were further investigated for familial adenomatous polyposis and were followed up for progression into RP adenoma or adenocarcinoma. So, to conclude, CHOPY can be detected on a routine ophthalmic evaluation by indirect ophthalmoscopy in all the asymptomatic cases. Baseline systemic evaluation for familial adenomatous polyposis which can significantly improve the life salvage rate in cases for colorectal malignancies by its early detection. Regular follow-up is indicated to see its progression into morphological changes such as RP adenoma or adenocarcinoma. Thank you.
How frequently do you call these patients for follow-up?
So if it's a patient without familial adenomatous polyposis, we call them initially every 3 months, and after a year, we call them every 6 months.
Okay. And in your case, only atypical therapy was associated with
Yes.
FP.
Yes.
What does the literature says? What is the percentage of association in the atypical CHOPY?
Yeah, so all the cases, like I have already mentioned, all previous study were done already in cases with familial adenomatous polyposis. They were the shields and all the studies were done. All the studies are retrospective studies. So it was done in cases with familial adenomatous polyposis and CHOPY was detected. Our study was the only study which followed
You
up.
proceeded with the CHOPY first as a
and then we
diagnosis and
detected
then
familial adenomatous
even
polyposis.
Shields they did they had the reference
so
for those.
Shields actually had this study on progression to RP adenoma and adenocarcinoma. It was not associated with, it didn't focus on familial adenomatous polyposis. It focused on progression to RP adenoma and adenocarcinoma.
So could it be that your comparison with the studies is different because in other studies it's already a defined colorectal problem and then they are taken
Correct.
CHOPY is a finding.
Correct.
So your numbers could be 70 increase so much so because you're taking CHOPY which is otherwise a benign condition and can be
Correct.
just
Ignored.
So if you would otherwise compare your 11 cases
11
which
cases
were
with
having
atypical CHOPY and out of them 6 had
only
familial.
6 would be actually eligible to be compared with them, isn't it?
Yes, sir. That's why this study was study to focus on the progression of CHOPY.
Progression of CHOPY.
Progression of CHOPY into RP adenoma, adenocarcinoma, and also early detection of familial adenomatous polyposis in otherwise asymptomatic cases.
One more observation from this chart, the lesser the number sample size, higher is the mean age group. But in most of the study, the age group is very less, around 30, 30, 45. Shield study, 65. Means sample size is skewing it towards the age group also.
Standard deviation can be more if the sample size is less.
Okay, thank you, Ruju. Can we have the next speaker, Vinutha Shri? Yeah, we have not reached 4 actually. We skipped this because she had to go.
Good morning, everyone. I'm Dr. Vinuta Shriyar, and I'm going to present about a case report of a small blue cell carcinoma, adamantinoma like Ewing sarcoma causing proptosis. Slides. So coming to our OPD was a 42-year-old female patient presenting with redness and swelling in the right eye lower eyelid since 2 months. She complained of diminution of vision and also history of restriction of movements were present with no history of any ocular trauma or previous surgeries. Patient had consulted a private clinic where oral steroids were given and abruptly stopped after 3 days. Coming to the anterior segment examination, we could find that there was abaxial proptosis in the right eye with swelling in the lower eyelid, but other parameters appeared normal. On inspection, we found that there was a right eye axial proptosis, but the other parameters from the inspection, for example, Valsalva maneuver and all, were all normal. Coming to the palpation, the inspective findings were confirmed. Finger insinuation test was positive as we could insinuate the fingers between the globe and the orbital rim, but on retropulsion test we felt a resistance on pushing the globe backwards. There was no thrill, supraorbital, infraorbital anesthesia and no bruit auscultation. On the proptosis evaluation we could find that all the parameters of the axial horizontal and vertical dimensions of the right eye were 5 mm more than the left eye, indicating that there was an abaxial proptosis of the right eye. Coming to the MRI, we found that there was a mass in the retroorbital region pushing the globe of the right eye downward and outward. We further took the patient for an anterior orbitotomy where right eye vertical lid split was done and debulking of the mass was done, and the mass that can be seen here was sent for histopathological examination. On histopathological examination, they had given a preliminary report of a small round blue cell carcinoma, query retinoblastoma or neuroblastoma. As we can see in this image, there were multiple small round blue cells. And on this image, we can find that there were pseudo rosettes present. On further sending the patient for IHC reporting, we found that the patient, it was positive for CK, EMA, synaptophysin, chromogranin, NSC, CD99, P63 and negative for LCA, S100, Desmin and GFAP, which gave an impression of the adamantinoma like Ewing sarcoma. So ALES is a rare malignant tumor which is characterized by EWS1 is to LF11 related fusions and complex epithelial differentiation. ALES poses a tremendous diagnostic challenge owing to its resemblance to a wide variety of common head and neck malignancies. It's a rare aggressive malignancy that mimics diverse neoplasms in the head and neck region. Awareness of the morphology and immunohistochemistry spectrum of this tumor is really important to avoid the diagnostic errors. Diagnosis of this type of tumor is based on its histochemical and immunohistochemical characteristics. For an Ewing sarcoma, it contains glycogen, so it will appear as PAS positive and also immunoreactive for NSC, Vimentin and S100 protein. A recent study also demonstrates that it is highly immunoreactive for CD99, which is indicative of high expression of MIC2 gene product. So the take home message for my presentation would be that IHC marking is very important and also molecular genetics is really important for correct diagnosis of the malignancy. Because in the earlier report it came as retinoblastoma or neuroblastoma, but on IHC reporting we could finalize that it was an adamantinoma like Ewing sarcoma. So so we can have facilitate a more accurate subclassification and tailored therapeutic approach. Thank you.
In your case, how long back the patient had that proptosis?
She had, she presented to her OPD with swelling in the right eye since 2 months.
2 months.
Yeah.
Or was there any other time lag? I want to ask, there is no metastasis in your case. You operated and it was...
We have sent for a PET scan because she came at 2 months back. She had it from 2 months, but she reported to her OPD like around 2 weeks back.
So PET scan is free?
It has been done now recently, and we could find that there was a metastasis in the liver. So it is now presenting as a metastasis of Ewing sarcoma. metastatic like Ewing sarcoma. So previously we had diagnosis for retino and neuroblastoma. We were suspecting that, but she wasn't responding to the chemo or the radiotherapy. So we further sent her for IHC reporting, where it came as adamantinoma like Ewing's. So on further diagnosis on a PET CT, we found that there was a metastasis in the liver. So now aggressive treatment has to be started for her, and she's complying for the same.
What does the literature suggest to you? How much is the metastatic rate and what is the prognosis for these type of patients?
According to the literature, the metastatic rates, first of all, Ewing's is a very rare malignancy in adult to present in an adult patient. But so metastasis will be more common in, like if it is already a rare presentation in an adult, there will be chances of metastasis as well. So around 1%, according to the literature in the article which I read, 1% of patients will have metastasis, and prognosis is very poor in such cases.
So your patient was very unique, having that was like 1% of the literature.
Yes,
that means so you should follow this patient further.
Yes, sir, we are trying.
So, like the pathologist whosoever use the marker, so is it possible? I mean, who decides ki, suppose this is not usual tumors which you suspected? For my own practice, I am asking you. So, can it be done in the first go itself, so as to save time? If there is any metastasis, we can prevent it. I mean, take up the case earlier. So who?
So that is the aim of my case today, ma'am. That to
okay,
start.
if it's not responding, then you go back, ask them to use more marker, then you come to a diagnosis,
like
and by that time metastasis is already there.
No, ma'am. Like to start, like not to rely on the HP report and to send for IHC marking immediately.
Generally, if the pathologist is not very clear of the pathology, and they already write it as a last line that most of the times they subject the specimens for IHC, they at least recommend. So immediately once you have the basic histopathology in your hand, you can get a IHC done, should be done, so that you know the details of the tumor as well as the stage and marking.
Again, she said it's a very rare tumor. So do we, while we ask them for IC markers, do we go for all rarest tumors or the commonest one? Because most of the time
There are two ways of doing IHC. That also depends upon which center you are sending. One is they will direct their markers to the target which you are asking them to do. And second is they will keep on doing till they get the proper diagnosis. So it's always nice to have the second part done so that they reach on to a conclusion. Not very expensive. There is generally a 2,000-3,000 difference, but then otherwise it is there.
Thank you.
Next is Nancy Sharma. This was Vinita Shri.
Nancy. Number 110.
Good morning, everyone. So I'll be presenting my free paper on the topic Pigmented BCC, the uninvited guest at 30. It's not working. Okay. So BCC is indeed the predominant form of skin cancer, predominantly afflicting sun-exposed regions of fair-skinned individuals aged over 50. It constitutes a substantial proportion of malignant eyelid tumors, accounting for approximately 90% of cases. It's not moving. टाइमर शुरू से लगा दीजिए. BCC is indeed the predominant form of skin cancer. It constitutes a substantial proportion of malignant eyelid tumors. Still not working. However, the occurrence of BCC, particularly younger individuals, remains relatively uncommon. This case highlights the rarity of BCC in a 32 years old female, underscoring the importance of recognizing atypical presentations of this malignancy. Our patient was a 32 years old female presented with painless black lesion located just above the medial canthus of her left eye, progressively increased in size since 8 months. The patient denied any visual disturbances. So this was the patient. The lesion measured approximately 5 mm in its largest diameter and exhibited no color variegation or discharge. Upon examination, it displayed well-defined margins and a lobulated surface. On the basis of history and examination, the differentials of melanoma, pigmented BCC, melanocytic nevus, and melanoacanthoma were made. The patient underwent counseling regarding the surgical excision, which is gold standard. The objective of this procedure is to achieve complete removal of the affected tissue with clear margins. Following the excision, the histopathological examination was done. And these are the pictures of the patient post-operative day 2nd, 7th, and 14th. Histopathological examination showed a tumor of long, thin branching anastomosing strands of BCC with some strands showing connection with the surface. There were nest of cells with peripheral palisading and retraction artifact. The cells have well-defined borders with oval to elongated spindle-shaped nuclei with minimal pleomorphic fine nuclear chromatic and inconspicuous nuclei. Cytoplasms show heavy pigmentation at bases. So these are the pictures of the histopathological slides. First showing the gross specimen of the nodular growth, second showing the peripheral palisading, and third the retraction artifact and scattered melanin pigments. After his histopathological examination, the patient was scheduled for resurgery to achieve tumor-free margin. Sorry for the bad picture. Unfortunately, the pictures were misplaced. Further excision was done and filling of the defect with Limburg flag was done. Limburg flag was created and advanced over the defect, and histopathology of the excised tissue was done, and it did not show any evidence of BCC. Now the patient is under follow-up. This is a picture of the patient post 7 months of Limburg flap reconstruction. BCC stands as the most prevalent type of skin cancer. It manifests in various forms, including nodular, pigmented, cystic, superficial, micronodal, morphiform, and infiltrating, nodular being the most common. While BCC infrequently metastasize, they possess a notable propensity for local destruction. Pigmented BCC is both a clinical and histological variant of BCC, distinguished by the presence of brown or black pigmentation. This subtype accounts only for 6% of all diagnosed cases. This case underscores the uncommon occurrence of pigmented BCC in a 32 years old female. Pigmented BCC may resemble other lesions also, as described earlier. Clinical differentiation based solely on morphological can be challenging, necessitating histopathological examination for definitive diagnosis. In this case, the absence of symptoms and the patient's young age further complicated the diagnostic process. The preferred treatment usually for pigmented BCC is surgical excision. MMS technique is usually done for larger BCCs. Following treatment, the recurrence of BCC same site is possible. Notable characteristics of BCC is its tendency to recur in new locations in individuals previously affected. Approximately 50% of patients with a history of BCC have the potential to develop a new skin lesion within a 5-year period. So in conclusion, this case highlights the rare occurrence of a pigmented BCC in a young patient and emphasizes the importance of histopathological evaluation for accurate diagnosis, and surgical excision remains the primary treatment modality with careful consideration given to cosmetic outcomes and preservation of function, especially in periocular regions, and regular follow-up is essential due to the potential for recurrence at the same time or development of new lesions in previously affected individuals. These are my references. Thank you.
What other ways could you have reconstructed that area? What are other ways of doing surgeries in that area?
So we can use, sorry sir, I have no idea regarding this.
Take Limburger's plan.
Sorry ma'am?
In this case, you Limburger's plan.
So that was done was a plastic surgeon in our case.
Which center you are from?
Ma'am, sir, GMC Jammu.
Thank you.
Thank you so much.
Do we have Saraswati Kannati by now?
Good morning, everyone. My name is bit of odd man out. It's not a clinical thing, it's a bit of basic research. Melphalan and the boron nitrate nanotubes in the eye using density function theory study. So basically we all know there is a global burden of cancer and it is catching up, and by 2050 we can expect 30 million people with cancer being detected, and no eyes being no exception, with all types of melanomas, lymphomas, sarcoma and carcinoma. So what are all the challenges? These are general challenges in cancer management, awareness being inadequate, there are a lot of misconceptions and taboos, and it's a huge economic burden both at the individual and the societal level, and there's a disproportionate distribution of healthcare and added to the expensive and inaccessible options, and even expert healthcare requirements are not adequately met with. And at the patient level, there's a long stay with the systemic complications, permanent disability, and insufficient rehabilitation, as we had seen in real time with the previous presenters. We can diagnose, but they're lost to follow up because of various social reasons. So what are all the recent advances? So all the ocular tumors are being customized. The treatment is being customized with various options like surgery, radiation, targeted therapy, immunotherapy, reconstructive procedures, and even sometimes clinical trials for the new treatments. I would like to concentrate on the targeted therapy. So targeted therapy, we all know, to avoid the systemic complications, because most of the complications are because of higher usage of medication, as we have to give it intravenous, though we do give some intravitreal and intraarterial, though they are not very commonly practiced. So nanocarriers could be the answer for the targeted delivery with their 10 to 100 nanometers size, and various tubes, nanocrystals, polymers, liposomes are all being tried for this, and among these nanotubes emerge as a unique nanocarriers because they have a high surface to volume ratio among the other properties. Carbon nanotubes were studied initially for the biological application, but then they fell out of favor because of the biocompatibility issues. Then came the boron nitrate nanotubes, which are similar to carbon nanotube in most of the structures. And this Ciofani et al. Have done extensive studies regarding the biocompatibility, and it's been established. The other challenge is making them dispersible. You can't make them into a solution, so we have to do a bit of surface functionalization with other groups to make them dispersible, which can be applied in medical use. So the novel idea what is being conceptualized is because melphalan is being used in various ways in eye, intravitreal, intraarterial, and even subconjunctival. So we thought we can take it up melphalan and see whether it can be used as the targeted therapy, and various routes of administration can also be tried. With the BNNT, as I've already told, they have been functionalized with OH group to make them dispersible. So density functional theory is basically based on a solver equation simulation. To make it simple, basically by simulations, by running various computer-based simulations, it can predict whether there is a possibility of conjugation of the drug and the carrier. So it is a computational study. These are the BLP, B3LYP is the commonly used technique. It involves initially optimizing the drug, and then these are all the various parameters. Basically, we study the angles and the bond length and other things, which is more feasible for conjugation. Then comes the carrier, again that is optimized with the OH group in place with the various parameters. And this is the finally it looks how the computational optimization looks, and this is the boron nitrate. It is a hexagonal structure, and then we have tried various locations of the OH because that again determines the drug carrier conjugation, different variations. And finally, this is the formula based on which the adsorption energy is calculated among various parameters. This gives as an idea as to whether the conjugation is possible. So we can see that melphalan can be engulfed inside the nanotubes we have tried various diameters. 8.28 was the optimal thing. So the adsorption energy was found to be minus 0.138 CV Hatry. Basically what it means is it shows there is a possibility of loading the melphalan inside the nanotube without the aid of any external simulation, and it also confirms the spontaneous adsorption inside the thing, and it can also very well carry the drug to the site before it undergoes other changes. But these are the very nascent results. At least the concept is favorable, because it has to be, nano drug delivery is a promising technique, but I being unique with a lot of barriers, it becomes even more challenging. But they hold a hope because of their huge payload, and the same kind of drug concentration can be attained even with the subconjunctival subtenons and topical instillation, which can help in reducing the morbidity, so that it can be practiced in the existing setup. But the bigger challenge is we have to validate the study with various cell line studies and animal studies, and also from the nanotube point of view, they have to be, the size has to be determined, it has to be upscaled before all these things can be done. So I would like to acknowledge these people who have helped me with the DFT studies. So the references, and thanks.
Do you have a clinical establishment with your institute, or you are into a research wing?
No, I'm a practicing clinician with Agarwal's Eye Hospital, and I've also done my PhD in drug delivery.
Wow. That's what it's
Yeah, yeah. So I'm just, I try to make it simple. I'm just trying to bring the gray areas in our clinical practice with the basic research. So in my own study, I have done on zebrafish. Have tried to instill the boron nitrate conjugated melphalan over the contact lens. So it has shown promising results where the drug is infusing into it. But as I've told, it has to be, validated.
So far, only one drug, melphalan, you have tried with that carrier.
Yes.
So others can also be in due time.
Yes, that is the thing.
So have you tried this
I have
in
tried
a clinical trial, melphalan on human?
No.
So still in that phase.
Correct. I have only done the zebrafish, which is accepted as a small animal study. It's accepted as a small cell.
Good one, very good.
Yeah, thank you.
Hope you succeed so that in future we also succeed. Yours, ma'am, here is Saraswati Karnataka.
Yes.
Thank you. Next one, second page. Dr. Rishi Sharma is not present. Only one is left. Dr. Nabya Kesi, please come.
Yeah. Good morning, everyone. Myself, Dr. Navya, and today I'll be reporting a case of a rare tumor of conjunctiva. That's the conjunctival malignant melanoma. So, conjunctival melanoma is a malignant tumor arising from the melanocytes of the ocular surface. It accounts for 2% of all the eye tumors, 5% of melanomas of ocular region, and 0.25% of the melanomas overall. So the precursor lesions like primary acquired melanosis and conjunctival nevi are the risk factors for developing melanoma. Because of its potential lethal neoplasm, it has like a 10-year mortality rate of almost 30%. So coming to my case, it was a 45-year-old female presenting with the complaints of brownish black pigmented lesion in the conjunctiva since childhood, which has increased in size from past 1 year. She had no other visual complaints, no systemic complaints like weight loss, cough, or fatigability, and no other similar complaints in the family. On examination, vitally she was stable. There was no lymphadenopathy. On systemic examination, no respiratory symptoms or no organomegaly. On ocular examination, the patient had a vision in the left eye of 612 improving to 6.9. There's a brownish black lesion involving the bulbar palpebral conjunctiva, including the lower fornix. You can also see the feeder vessel on the temporal side. The extraocular movements were full in range and painless, and fundus was within normal limits. We went ahead with wide local excision of the lesion with no-touch technique with amniotic membrane transfer, and cryotherapy with double freeze slow thaw mode is delivered to the margins. And the specimen sent to histopathology reported a nuclear pleomorphism and oval-shaped nuclei with increased NC ratio, a good number of tumor cells with melanin pigment deposition. And these features suggested of conjunctival malignant melanoma of epithelioid variant, but all the margins were clear of tumor. FDG PET CTs showed no metabolically active lesion in the left orbit, neither in whole of the body. And post-operative on follow-up visit, she was started on topical chemotherapy with mitomycin C, 6 cycles, and the patient is kept on regular follow-up to rule out see for any recurrences or metastasis. Coming to discussion, conjunctival melanoma is a rare but has a high mortality rate. Rapidly growing melanocytic lesions in the conjunctiva should be closely examined to rule out malignant melanoma. Systemic evaluation is a must to look for nodal and extranodal sites of involvement. And metastasis and recurrences are very common in melanoma, necessitating the long-term follow-up care. These are my references, and thank you.
Frequently you are calling the patient?
Ma'am, like when initially we started, we called her like every 2 months. And the CT we are doing, like PET CT, we are doing it every 6 months, like to look for metastasis. Right now she's on 4 months follow-up.
Okay. Would you show me the clinical picture once?
Yeah. Yeah.
So how widely you had to excise the conjunctival part?
Ma'am, almost like 4 mm margin we left. Since clinically it was almost like a malignant feature. 4 mm margin in both the medial, lower fornix and the lateral side as well.
And on that side, upper bulbar conjunctiva also there is some part
yeah.
What is that?
It was actually the one which is extended to the cornea was a pterygium, not exactly the melanoma.
Okay. But it's pigmented, no?
Pigmented.
Brownish pigment we don't get in pterygium.
Yeah, we had excised that as well.
So what was that on his HP?
It was malignant tumor only, but the corneal part was not the malignant.
So it has actually gone to that part also.
Yes, ma'am.
Okay. Thank you so much.
Yeah, thank you. I'll repeat. No, not an issue. No problem, sir. Sir, I'm sorry. I told you. कोई बात नहीं.
Sir, only one person is the last, second.
Navya.
Okay.
First slide.
Navya. Okay. I don't know that I could have waited.
Should I start the timer again?
So don't worry about the timing.
Yeah, can I just, okay. So today I'll be presenting about a case report of a rare tumor of conjunctiva, the conjunctival malignant melanoma. So conjunctival malignant melanoma is a tumor arising from the melanocytes of ocular surface. It accounts for 2% of the all tumors, all eye tumors, 5% of melanomas, and 0.25% of the melanomas overall. So the precursor lesions like primary acquired melanosis and nevi are the risk factors for conjunctival melanoma. It's a potential lethal neoplasm with 10-year mortality rate of 30%. Coming to my case, it was a 45-year-old female patient presenting with the complaints of brownish-black pigmented lesion of the conjunctiva, present since childhood, but has increased in size since 1 year. She had no other ocular complaints, no systemic complaints of weight loss or fatigability or cough, and no similar complaints in the family. On examination, she is vitally stable, no lymphadenopathy noted. On systemic examination, nothing significant, no organomegaly or any respiratory symptoms. On ocular examination, she had a left eye vision of 612 improving to 6.9, a brownish-black raised lesion involving the bulbar, conjunctiva, palpebral, and the lower fornix was noted with a feeder vessel. Then extraocular movements were full in range and fundus was within normal limits. Management, we went ahead with wide local excision with no-touch technique with wet amniotic membrane transfer, and cryotherapy of double freeze slow thaw mode is delivered to the margins. On histopath examination, the tumor cells were noted with increased NC ratio, nuclear pleomorphism. And the tumor cells also showed melanin pigment deposition and suggestive of conjunctival malignant melanoma of epithelioid variant, but margins were clear of tumor. The FTG PET CT showed no active lesions in the left orbit, neither the whole body survey. The post-operative patient was started on adjuvant topical chemotherapy with mitomycin C with 6 cycles, and patient is kept on regular follow-ups, and as of now, no recurrence noted. So on discussion, melanoma is a rare but case with a high mortality rate. So rapidly growing melanocytic lesions in conjunctiva should be closely examined to rule out the malignant melanoma. Systemic evaluation is a must to look for nodal and extranodal sites, and metastasis and recurrence is very common, so patient has to be kept on long-term follow-up care. These are my references. Thank you.
Did you do an incisional biopsy before taking or straight away
We went ahead. It looked more like a malignant tumor, so the presentation.
Generally, where do you practice?
So Regional Institute of Ophthalmology, Bangalore. Yeah.
Generally, because with these type of lesions which are very high on metastasis, could be fatal, and it's always nice to have an incisional biopsy.
No.
Because you also have to be prepared about what extent you need to go, and if you are dealing with something which is malignant, you have to do more of excisions, destructing, sometimes destroying the structures, important structures around. So for that, you have to be really 100% sure. Should not be based on the clinical especially when you have such a easily takeable lesion. And then actually the patient and the attendants are also much more convinced to have a larger surgery. So they get time to adapt to these type of shocks, which is like having something in the eye and having a malignancy in the eye. Okay, what all other chemotherapeutic drugs can be used for these type of lesions post-op?
So I have used
mitomycin. Was there any study which has used mitomycin over this?
Sorry, sir?
Was there any study which is used?
Like there are a lot of studies actually which say that mitomycin might prevent the recurrence, and it acts as adjuvant therapy. Even if the tumor margins are not clear, sometimes where you can't do extensive clearance, mitomycin will help in
What concentration of mitomycin you used? You didn't use.
Were you present during surgery?
Sorry.
Were you there during surgery?
I was not there. No.
Anyways, that was a very submission is good that you have clearly said no to it rather than beating about the bush. Thank you.
Thank you.
Let's have the photograph with the speakers and then we'll conclude this session. What's your number? Not.
Good morning everyone. I'm Dr. Rutuparna. I'll be presenting a case of unilateral panophthalmitis following dengue fever. We know dengue fever is an acute febrile illness caused by a flavivirus transmitted through the bite of female Aedes aegypti mosquito. Clinically, it presents with fever, joint pain, headache and a macular papular rash. The disease can become life-threatening with severe hemorrhagic complications, significant capillary leakage leading to dengue shock and potential damage to vital organs. Panophthalmitis is the inflammation of 3 coats of eyeball including surrounding soft tissues and orbital involvement. It is a rare but severe ocular complication of dengue fever. Pathogenesis, it can be caused by direct spread of organism, secondary infection or from the mediators of immune response. Case summary, a 53-year-old female presented with sudden painful profound diminution of vision since 1 day, pain in right eye since 3 days, swelling of the eyelids of right eye since 3 days and history of fever 10 days back. On examination of right eye, visual acuity, no light perception was present, lead edema, proptosis of the eyeball, diffuse congestion and chemosis of the conjunctiva. There was corneal melt and anterior chamber, lens and posterior segment details were not visible. The differentials can be endophthalmitis, orbital cellulitis or orbital abscess. Different points in favor of panophthalmitis, proptosis, conjunctival chemosis, corneal melt and absence of perception of light. Points in favor of endophthalmitis would be lid edema, conjunctival congestion and chemosis. Points against would be corneal melt and present and anterior chamber posterior segment details are not visible. Points in favor of orbital cellulitis would be proptosis, lid edema and chemosis. Points against would be corneal melt present and anterior chamber details are not visible. The investigation we did a platelet count of the patient was 179.5 thousand per cubic millimeters. The lymphocyte count was 15.5. TLC was decreased, that is 3.5. Dengue NS1 antigen was positive. And PC was also decreased, 32.7. The diagnosis is dietary panophthalmitis with active dengue infection. The treatment given, primary treatment was frill evisceration on table, auto expulsion of crystalline lens was noted. Secondary orbital implant was planned after that. The histopathology of episcleral tissue showed areas of hyalinization, fibrosis along with moderate acute inflammation and congested blood vessels suggestive of epithelial hyperplasia and dense acute inflammation. Scleral and uveal tissue showed extensive areas of necrosis, hemorrhage and dense acute inflammatory exudate suggestive of necrotizing acute inflammation consistent with panophthalmitis. In microbiology, in Gramston, no inflammatory cells or bacteria were seen. In aerobic bacterial culture and sensitivity of corneal button, no growth after 48 hours of aerobic incubation was seen. Then coming to discussion, this case explains the rare occurrence of panophthalmitis as a sequelae of dengue fever, hence the importance of early diagnosis and intervention to prevent severe ocular complications. The complete ophthalmic evaluation, prompt intervention are essential for managing individuals presenting with dengue-associated ocular symptoms, helping to prevent irreversible vision loss and need for evisceration and hence improving the quality of life. Here are my references. Thank you.
Dengue generally leads to hemorrhagic insults to the organ. Yours wasn't infective. Was there any other condition?
No, there wasn't any infective condition.
No diabetics, nothing?
No, she wasn't having any chronic systemic illness.
So couldn't it be a cause of some other endogenous infection which is leading to the endogenous endophthalmitis in your case?
Sir, it could be or it could be due to immunologic factors, IgG.
Just tell me key points to differentiate endophthalmitis from panophthalmitis from orbital cellulitis.
Sir, in endophthalmitis, there is conjunctival congestion, chemosis, cornea might be hazy, but the anterior chamber details and posterior segment details are visible.
Not necessary.
Sir, we can see vitreous exudates. In panophthalmitis, corneal melt is present and
It can be present in endophthalmitis also.
Sir, in panophthalmitis, there is restriction of movements which is
So that's what you're getting confused. In panophthalmitis, the sclera gets involved, right? In B scan, you have a scleritis. You have a fluid level behind the sclera. So that differentiates the endophthalmitis from the panophthalmitis. In end of the sclera part is not involved. Whereas in orbital cellulitis, the extraocular motility is restricted. In panoph and endof, it's not generally restricted. So those are the differential points, right? And why did you do secondary implant? Why not primary implant?
Sir, there was already inflammation, so we let the inflammation.
After how many days did you do secondary implant?
Sir, 1 month.
After 1 month, you won't be able to do secondary implant. The whole of the sclera would become a bunch, right? So there are two schools of thought. Some think the way you are thinking that secondary implant should be done. But I personally feel the primary implant should be done. What if patient would have an extrusion of the implant? That's the worst thing will happen.
We put conformer and we...
Conformer is from the outside, na? Implant has to go inside.
Implant has
So if you have removed the pathology, if you are giving anti-inflammatory to the patient, most of the time, more than 70% of the times, implant stays in place. Rest 30% you will have to struggle because in 1 month's time, the scleral part which you have left after doing evisceration would crumple into a small segment. So you won't have space to put implant within the scleral cup. You will have to do something behind the sclera or like an enucleation. That won't give that good an effect as you would have as a primary implant. So my take is you should do a primary implant wherever possible, even if you had high chances of implant exposure, right?
What was the technique for secondary implant? How much amount of sclera? You said frill excision was done. How much amount of scleral residual was there?
Ma'am, actually I wasn't present during the surgery, that's why.
Any other speakers? Do we have any other speakers?
Sir, I'll just confirm. Dr. Rutuparna Mohapatra is, she presented. Dr. Hemlata is not there? Then Dr. Rishi Sharma, not there? Okay.
Can you, all the speakers kindly gather near the stage for the quick photograph so that we can vacate the hall for the next session?